So then we move to the next speaker this morning, that is Dr. Fausto Риgo. And Fausto is going to speak. Let me see the title of your talk. His lecture is entitled, What's the Evidence for Coronary Flow and Outcomes? So Fausto is a great expert in echocardiography and has done extensive work on assessment of coronary flow through echocardiography, and I'm sure that we look forward to your talk, Fausto. Thank you.
Many thanks, Javier, for your introduction. First of all, I would like to thank Justin and the friend of St. Mary's Hospital, Imperial College, for inviting me here to talk about what's the evidence for coronary flow and the reserve in outcome of patients. As learning objective in this talk, I want to convince you what is the role of coronary flow reserve in patients suspected of having ischemic heart disease, why and how should we assess CFR non-invasively, and the role between CFR and outcome in clinical practice. As we have taught in Brown text, prognostication using functional non-invasive stress test is based on the rationale that physiological alteration under stress condition predicts events better than those knowledge of coronary artery anatomy. But often we forgot this important crucial point. And for patients with stable angina, any vessel to be dilated must be shown to be associated with a moderate to severe degree of ischemia on non-invasive testing. And I would like to start my talk with a clinical case, a real world. A female, 68 years old, with hypertension, treated with beta blocker, diuretics, nalopril, overweight, chest pain, not clear chest pain, atypical, typical, like a woman. A trivial dyspnea, and SEG, we have a left bundle branch block. Here you can see the resting echocardiography. You can see patient with hypertensive cardiac disease. And here you can see with color Doppler the presence of mitral regurgitation and alteration in terms of left ventricular mass and alteration of diastolic function. Which test would you have suggested in this patient? Exercise test? How many of you? Good. Myocardial scintigraphy? Oh. Stress echo? Good. CT scan? Coronary angiography directly? Only one. Okay. Nothing? Well, looking at what the guidelines say, in Europe we have the patient with intermediate risk factors. We can apply stress echo as well as nuclear imaging, stress MRI, and PET perfusion. But the guidelines summarize and try to support us in choosing the test, looking at deeply the case. In this case, we have a patient with hypertension, with left ventricular hypertrophy, and therefore probably scintigraphy, it is not the suitable method in this case. Probably stress echo is easier to perform and give us much more information in this particular setting of patient. And we take into account also the advantages of kind of stress, the specificity, the availability, and the cost, and above all, the presence of radiation burden. And we address the patient, stress echo. We don't have any information in terms of differentiation between resting and after injecting vasodilator agent. And we judge this kind of examination negative for ischemic induction. We know very well that the prognostic value of stress echo and SPECT, we have the same value in terms of predicting the outcome of the patient. And when we have an induction of ischemic disease, we have a strong information in predicting, regardless the test that we apply, stress echo or system AB. And we know very well, has shown, demonstrate with this meta-analysis that importance of the magnitude of induction in terms of ischemic disease. And it's important to define the risk in various modalities because starting from the kind of induction, we can stratify as well as possible the risk of the patient. High risk with a mortality higher than 3% per year, intermediate risk with a mortality between the 1 and 3% per year, and the low mortality when we have severe mortality lower than 1 per year. And regardless the test that you apply, we have this answer that we have in high-risk patient, we have benefit from revascularization, and therefore we have to push the patient in this direction. When we have a mild risk between 1 and 3%, the benefit from revascularization we have only in three-vessel disease or left-main disease, and in patients with a low risk, lower than 1%, we have that benefit from revascularization, and we should take into account in management of our patient. And recently, Goodlands, the father of ocular reflex, proposed his concept in terms of CFR, looking at what's happened in terms of in perfusion. In other words, he replaced the concept of critical of coronary narrow and replaced this concept with the perfusion defects given by the coronary artery. This is very important to take into account in the clinical practice to look at what's happened really in terms of impairs on myocardial perfusion given by a narrowing of coronary stenosis. And we have that to stratify the risk by stress test is very important because, as demonstrated by Akamovich in this elegant paper, when we reach the magnitude of perfusion defects, such as 10% on higher, we have a worsening outcome for the patient. And this is a strong point that we should take into account in daily practice. And here, when you face this problem, try to guide better the revascularization, applying anatomical and SPECT imaging, we have the possibility to stratify as well as possible in 3 different categories the patient with different outcome. And here, Dr. Negia demonstrates that by integrating CT scan with perfusion unit, we can better select patients for invasive coronary angiography. And therefore, we should strengthen our care in this direction. 15 years ago, I tried to address this study non-invasively, mimicking the cath lab, and try to address our ultrasound inside LV, such as you can see here. And we found that the feasibility was high, 98%, and we had the possibility to map and to test CFR in this particular artery and to have information about coronary flow reserve, very, very similar to cath lab.
Fausto, can you go back to that lovely image and show us the? So which artery is that you're looking at?
What?
When you see that play.
Yeah, here we can see the left anterior descending coronary artery in the mid-distal part tract that is very clear to anatomy, and it's very easy to assess employing particular delivering frequency of probe and particular angle cut that we can have from transthoracic approach, a common transthoracic approach.
Yeah, so there's no special equipment. It's just,
No.
So it's just your normal echo machine.
We have a commercial machine. Obviously, you have to set the frequency. You have to set the filters in terms of wall noise, in terms of highlight the coronary flow. But you don't have any particular magic machine. No.
Okay. Just a magic operator.
Yeah. Absolutely. And here you can see the concept of CFR that you know very well better than me. But this slide summarizes an important concept that with CFR I can assess epicardial function and microvascular function. Looking at this slide, I have a limit of CFR assessed by non-invasively because I don't know where exactly we have the impairment of CFR, epicardial or microvascular. But the advantage for me, a non-invasive expert, that I have an information on the whole circulation. And therefore, having an information on the whole circulation, I can stratify prognostically the patient, regardless the point where I had really the problem. And here I show you the protocol that we employ. We employ adenosine or diperitamol that give us the same hyperemic reaction and guarantee us the possibility to stress the patient, looking at what's happened behind the coronary in terms of wall motion and also in terms of coronary flow assessment and reserve. In other words, we have the double possibility of assessing at the same stress test. And here I show you what the first paper that we published. What's the advantages of this investigation? The advantage is that when I have a patient with a negative stress test based only wall motion score induction abnormalities, we can have in those patients frequently patient who really has an LD narrowing or coronary narrowing. And therefore, we can give an added value to stress echo that had some limitation in daily practice, giving a boost in terms of sensitivity that come up from the perfusion. Classically, we have the myocardial perfusion has a higher sensitivity but a lower specificity. In this case, we have the higher sensitivity given by the perfusion and maintain a good specificity given by wall motion contractility. And here you can see what we found. I published in a European journal 8 years ago. What's happened when we match the double information given by wall motion abnormalities and the presence of CFR normal or abnormal. We can stratify two opposite situations. When you have normal wall motion and normal CFR, you have the best situation. When you have the impairment in terms of CFR and the contractility, you have the worsening situation. And in the middle, you have an aggression. And an important information that we can get from this test that usually when you perform a stress test based only with wall motion, you have to stop the therapy because the therapy can mask the ischemic effect. By using coronary flow reserve, you can give to the patient the therapy and don't have any variation in terms of response of the test. And what about diabetic patient? In diabetic patient, we have a strong information because when we have a normal CFR and a normal response in terms of wall motion, we have a very similar outcome of patient without diabetes. And in this particular patient, we have the double information regarding the epicardial narrowing and also regarding the microvascular function. You know very well that sometimes the patient has a myocardial diabetes disease, that inside microvascular dysfunction, myocyte, that create a strong prognosis in this kind of patient. And having information regarding all the circulation is very, very important. And what about intermediate LAD stenosis? In intermediate LAD stenosis, that for a non-invasive expert represent a strong challenge, is very important to address earlier or not the patient to cath lab when you have this kind of response. And another important setting of patients represented by microvascular dysfunction, such as syndrome X, where we have a different response in terms of wall motion, a different response in terms of coronary flow reserve. And what about left bundle branch block, like the patient that represented our clinical case? Also, in this situation, we can stratify in different way the patient with the better outcome from the patient with the worsening outcome, looking at what's happened in terms of CFR. And in Italian network, we publish much more of 2,000 of patients, and we published this paper that represent a milestone in terms of predicting the value of predicting coronary flow reserve during the hyperrhythmal stress cycle. And we had the privilege of the editorial comment from Professor De Bruin that emphasized, as well as possible, the importance of ischemia, highlighting by CFR as a marker of outcome in this patient. In other words, when we have negative stress echo and CFR higher than 2, we have a good patient. We have a good outcome. We don't have any trouble. On the contrary, when we have a lower value in terms of CFR, we can have a worsening outcome. And going back to our patient, you can see here the patient 3 months later come back in the hospital with the same clinical situation, chest pain and dyspnea, and then we perform CFR. And you can see what's happened. We had a higher velocity in resting condition and the trivial variation in terms of velocity after injecting hyperemic agent, and therefore we found a CFR of 1.4. And here you can see the angiography response that we treated with stent, and we solved at the end of the day the problem of this patient that in the first part of our management result negative, looking at what's happened in terms of wall motion abnormalities. And another important concept that we published very recently as editorial, they recognize the value of coronary flow velocity and looking at what's happened in terms of gradient of velocity in predicting the outcome in this particular situation. And what we have learned from this brief talk, that the coronary flow reserve is feasible, reliable, by transthoracic echo, and very useful in highlighting the prognostic meaning of coronary circulation in very different situations. Functional tests such as CFR by TT improves the positive predictive value and our ability to detect hemodynamically significant coronary stenosis, allowing to identify a greater number of patients who can benefit from revascularization and could be employed in clinical practice, a screening tool in assessing coronary function before address the patient to cath lab, and it's very important to, in order to acting as gatekeeper in this particular situation. Thank you very much for your attention.
Firstly, thank you for a really, really excellent talk, and taking us to somewhere which is very different from where we've been in the last couple of days. Rick, you've got a question.
Fausta, amazing data. When we published on CFR before, I think the community has this feeling that the CFR is a pure microvascular index. And I think you very elegantly presented this as not being the case. If you have a normal CFR, you have no events, and in many ways, it doesn't really matter whether you have a stenosis in the middle of your LAD or not, because your flow is not impeded, whether you have an amazing microcirculation or not. And I think this is something that perhaps from the help of the non-invasive team like yourself, we have to transmit to the community in general, that if your coronary flow is preserved, it doesn't really matter what's happening in your epicardial artery, that you're not going to have an event, and it's very unlikely that pressure drop is causing significant problem. And your work agrees very much with Prof. Peek's work invasively in Amsterdam, and he's been doing it for like 10, 20 years, deferring patients with normal CFR. And again, as much as we study this, the more we find that flow holds the signal to events. So this is fantastic.
Thank you, Riccardo.
The other interesting thing for us as well is that if you were to present us with this data going into the cath lab, so for instance, if you said this patient's got a CFR which is low going to the cath lab, and I think that would be really helpful, because actually when the patient comes in, we do an angiogram and you make a physiology measurement and it's completely normal, then you know in that case it's likely to be a microvascular. So you've got the answer to many of the diagnostic questions that you want almost up front, and you can essentially make that decision and convey that to the patient very quickly and easily. Very, very interesting. How easy is it to do?
Depends on the training.
Okay.
Is to do, yes. After 100 stress echo, you can do it easily in every echo lab. I have a young physician, that young collaborator, that after 50, 60 stress echo, they are very, very, very able to perform directly CFR on LD. The problem is that, and the limitation, that we have good result in terms of assessment of CFR on LD. Another thing is posterior descending coronary artery, where we have high possibility to have a good envelope, a good trace, above all when we try to assess the response in hyperemic induction.
So this is just useful for LAD disease then, right?
Yeah.
So it's if this patient had a normal coronary flow, you still would need angiography because you haven't excluded the right or the circumflex.
It's a good question.
Because she had mitral regurgitation, and those vessels could have been feeding the papillary muscles too.
But we have a whole investigation, because take into account that you perform a stress echo in traditional way, looking at what's happening in the contractility in all left ventricle. You have information that guarantee you a good specificity, not only in LD territory, but also in circumflex and posterior descending coronary artery territory. And therefore, you have an added value, because you have a perfusion and an important territory where LD makes the difference in any case. And therefore, added this double information, you have in any case a result, a complete result in this patient, in this situation of patient.
Very simple but important question. If you passed your own non-invasive assessment of this patient, and final decision is that the risk of coronary accident is low, but the patient is still suffering from chest pain.
Okay.
Will you make coronary angio or not?
It's a good question.
And how long is
But,
valid your non-invasive assessment?
To be
Weeks
honest,
or months or?
Sure. To be honest, I must confess that also in CFR evaluation, we have a gray zone. In other words, when you have CFR between 1.8, 2.1, you have a gray zone where you don't know exactly if you have an intermediate, narrowing, or microvascular dysfunction, or the mixed situation. There, when you have a patient with very, very symptomatic, obviously, anatomical tool you have to perform, CT or coronary angiography, depends on the pretest probability, because if you have a lower probability in terms of coronary disease, probably it's better to perform CT scan, lowering the radiation burden. Consider if you have a woman or the man, the age, and so on.
But Fausta, what you've shown us is profound, though, in terms of the improvement you get from the CFR in addition to normal stress echo. Because you asked the question, and many people put their hand up for using stress echo as a tool, and many of us will say, well, the stress echo is normal, therefore the patient shouldn't come to the cath lab. But you've shown us the prognostic predictability of this technique is huge in addition to stress echo.
This is a very important message. Thank you, Justin.
No, Fausto, so I think it's a great talk. Thank you much. And of course, I mean, what this is truly important is to remember that what this gives us is an incremental value to any diagnostic text that we have, including coronary angiography. So you could envisage perfectly that if you don't have in your cath lab a facility to measure coronary flow reserve, but you have found, like we did yesterday in the live case, a patient, you see, you have normal, so to speak, FFR, for example, or normal IFR, etc. But still, you want to explore other domains of the coronary circulation and to understand better what happens to the patient. This is of enormous value. Now, so this I agree entirely with this. Now, something that again we learned from the case of yesterday is that the way of inducing hyperemia in this case can be critical. And yesterday we saw that in this patient we were infusing intravenous adenosine, and we were unable to induce hyperemia. So I think that we have to keep this in mind, because although I believe that these cases are rare, they happen, and you may have therefore a false positive by believing that the patient has microcirculatory dysfunction, when actually what happens is that you fail in achieving maximal hyperemia. If you are using exercise test, I think is ideal, of course, because you are. One of the great things that you are seeing here as well is that you are checking also endothelial-dependent vasodilation, which is extremely important. You may have a reduction in flow as a consequence of having a spasm of the arterioles. But I don't know what you think. And this probably brings the idea of saying that perhaps if these techniques go ahead, you need to think in alternative hyperemic agents that are more reliable than adenosine. Which of course are fraught by the fact of having a glass of coffee in the morning, for example. If you have a glass of coffee in the morning, forget about this.
Sure. I fully agree with you.
So it was very interesting, because I'm just going to make a funny comment. Recently we had a sort of a board where we were discussing all these things, and I was making the point of the coffee. You see, the coffee can be a real problem. And the person who made the transcription of the minutes, he said the coffee can be a great problem because it introduces shaking hands in the operator.
So the operator.
The concept that adenosine function, the adenosine hyperemic power is influenced by coffee is not very much generalized.
Thank you, Javier. But our experience, it has been only 1 minute, Justin. It was very, very important to change our mentality. Before applying this kind of functional test in cath lab, in my cath lab of Venice, everybody look at the stenosis, look at the narrow, without ask themselves how important the impact of the flow limitation of the narrowing. And giving a functional, non-invasive message changed dramatically the relationship with the cath lab in terms of investigate the function of the patient.
Fausto, just following on from Javier's question, may I ask, have you looked at whether you can exercise these patients and then look at the non-invasive CFR and see if that stimulus is different to adenosine, for example?
Absolutely, yes. Scandia demonstrated that reaction, the hyperemic effect, looking what's happened when you inject adenosine or dipyridamole, that indirect adenosine mediator, you have a completely different reaction. This is the reason why I try to apply adenosine, because when you have 2 or 3 increasing in terms of flow velocity, you are sure that the patient has a normal circulation. In terms of exercise, you have an increase in terms of 2 and not more usually, and sometimes it's very difficult to highlight a small variation in terms of velocity. But we are trying to perform this kind of assessment.
So are there any more questions here? No, if not, thank you very much, Fausto. That was a fantastic talk. Thanks a lot.